Thank you very much for making it back in time. We can see the ever-popular John Mandrola has drawn quite an audience, you'll see, John. So, we're enormously grateful that, and we feel privileged that you've accepted our offer to come here to our meeting, and thank you very much for your talk already this morning. It was exactly what we expected, and you set us out on the right path. You've had a bit of an arduous journey, I think, getting here. There's some hideous storm with snow, and we weren't sure if you were even going to make it, so thank you very much for your efforts getting here. You and I first met 10 years ago or so at the ESC. Now, you may not remember this, actually, but I do, because I was chairing a session where you were going to debate with Horst Sievert.
Oh, I remember.
Yes, on left atrial appendage occlusion. And the industry were very behind me. So I said, go on, Dave, go on, get him, take him down. And I remember at the time thinking how measured and steady you were with your gradual sort of destruction of the data. and I was very impressed, and I thought, you know, this is a very impressive character. And I've followed you sort of intermittently ever since then. And of course, now you're extremely well known, and people follow you in huge numbers. But what I'm really interested in is how did it all start for you in terms of, well, firstly, social media. So your first forays, what was it? Bebo, MySpace, and what took you to experiment with that?
Yeah, thanks for having me. First of all, it's a real honor, like I said this morning. Honestly, it's really an impressive place because of all the great research you do. I joined a private practice in 1996, and for the first 10 years, I trained in Indiana under Doug Zipes, and he was quite tough, strong, and really wanted us all go into research. But it was the heyday of SVT. It was the heyday of EP. It was also the heyday of interventional at the time, but also EP. We began to be able to ablate arrhythmias rather than just study them. And also, ICDs were transitioning from abdominal to pectoral. So it was a big time for EP. So I just wanted to practice, and I joined a practice. And then there was no EP in Louisville, which is about a city of 1 million people. And I just did procedures, kept my head down, nothing, 10 years. And then I just started writing. I didn't know how to write, but I learned how to write, and it was also the time of the blogs. So it was really not social media. It was really this sort of blog things where you write. Remember when mothers were writing about, they're called the mommy blogs, and all of my friends made fun of this blog that I made because they just said it was so Mickey Mouse. I mean, it was just a blog. And eventually, writing about medicine drew some attention amongst other bloggers and amongst journalists. And one day, the Heart.org just called up and said, we need a EP blogger, and you just do one post a month, and we'll pay you $250 for a post. There was no editing. I just typed it up myself, just hit transmit. Now it's like it's a huge process to publish.
So initially, it was right at the start a blog about medicine.
It was initially a blog about cycling, but within 3 weeks. Within 3 weeks, you can write everything that's ever been said in cycling. It's always the fastest people win, and it never changes. That's really cycling. And then after I got bored with cycling, I started writing about medicine. All of these things that became so obvious to me, these defibrillators in old frail people, and polypharmacy, and my wife is a palliative care physician. And so just all of the bad stuff that we do at end of life. And I started writing about things. No permission needed. There was no permission. You could just hit publish. Boom. It was out there to the internet.
So you didn't mind that initially, presumably, you were just writing into a void.
It was a void.
Yeah. And so were you doing it to teach yourself how to write?
Yeah, it became a challenge. I love new challenges. It's one of the things I like about EP. People said, I really didn't know how to write. I had no training. I got C's in English, took mostly science courses, and I just taught myself how to write. And the fact that I was so bad at it at first, and there's proof because you can find the first post. It's terrible. And I just read books on writing and became a challenge. But then what's interesting is that in about 2015, my editor came and said, John, nobody reads anymore. You need to do a podcast. And I was very against it. I said, look, Trish, I had just spent all these years learning to write better. And she said, nope, you gotta do podcasts. And those were also terrible in the beginning. But now, as you know, so many famous writers have also transitioned over to audio content.
Yes, and so right at the start, though, you must have been posting onto forums that we've forgotten the names of. I mean, is that how it's...
Yeah, it was blogspot.com. It was a Google thing. You could set it up, and then it became WordPress. And, and it was just, And then Twitter came along a little later, a few years later, what was pretty much just a way to try and boost content to the blog.
And you make quite a thing of not being an academic, but you're the most academic, not academic that I know, because you are very forensic in your analysis of clinical trials. Did this come, because in a sense you took what Phil McCarthy referred to, if I may, as a sort of job to do the doings of a cardiologist rather than to be in an ivory tower or something, and yet you're strongly academic. Did you have a journal club or something? I mean, what prompted you to be particularly interested in clinical trials? I mean,
it was really a process, and it was very similar to writing. I had, like I said, at Indiana, we were learning procedures because it was the heyday. We weren't learning critical analysis, so everything that I've learned about analyzing trials has been a slow process, starting from a really low level of understanding and gradually learning from generous mentors like Sanjay Kaul, who is amazing, and just reading about it. I mean, I've read books on the p-value. I've read books on statistics. I mean, I really like it, and one of the reasons why I like it is because I didn't know so much about it. And so people say, how do I learn critical appraisal? And I said, there's not a book. There's not one book on it. It's a process.
Yeah.
And so it just was a gradual thing.
And now, although you like it, I mean, it's quite a machine now. Is it all you that does this? I mean, you told me you were doing your podcast at 4 a.m. this morning. I mean, do you have a team of people? How do you maintain your enthusiasm every week?
The This Week in Cardiology podcast, it's just me. I create a script. I pick the trials. I have to wait until about Wednesday because most of the journals don't release until, New England releases on Wednesday, so I wait. And on usually Wednesday afternoon, Wednesday evening, Thursday morning, Thursday during the day between cases, and then Friday morning, I just find studies that I can talk about. Actually, Twitter is a really good source for studies because it's stuff that may not be so obvious from looking at it, and somebody will tweet something out. I'm like, oh yeah, I should look at that. And then I like to pick stuff that is maybe off the beaten path a little bit, and then I just record it on Friday, send the team an audio file. They do they have a technical team that does a little bit of tweaking to it. It takes out mispronunciations and stuff like that, but yeah.
Yeah. So, I think you've probably established already from the audience here and the response to your talk this morning, which was great, that we in Britain, we're a nation of natural skeptics. And if somebody comes along with something new, we mostly go, really? Really? Is that going to work? Are you sure? So you're very at home here, in this environment. But I do wonder, how do they view you in the United States?
Yeah. Well, it's not like Americans are that agreeable either. I think that my views are probably much more welcome in Canada, the UK, and cost-constrained systems. I don't usually get invited to any major U.S. cardiac meetings. You'll never see me on a hotline or late-breaking clinical trial as a discussant, which is fine because I'm not in the club, right? I'm not an academic, but I think I have some people who in the U.S. who don't agree with me at all.
Yes, yes.
Which is fine.
Yeah. Yeah, no, that's fine. I mean, you remind me with what you said there. I was on the panel for Triluminate at TCT, and I kept trying to press my buzzer to say I would like to say something, and I was completely stonewalled. It's like, don't go to him, whatever you do. And so you are a natural conservative then, with a small c. We had a great talk yesterday from Andy Bishop about the concept of whether people become more conservative with age as they perhaps get wiser or have seen more. So the question is, have you always been naturally conservative, or do you think you've become slightly more conservative with age?
No, I think I've definitely become more cautious and conservative with old age. I've lived through the many, the ICD problems, the Sprint Fidelis lead. We did a ton of Sprint Fidelis leads that ended up being a disaster. And I remember being at the scrub sink, them telling me, "Oh, the problem with this lead is just because you all are putting it in wrong." And yeah, so I stick with tried and true, and I really adopt things slowly. Except I have to say that the one place where I think I was wrong to be too skeptical was with pulse field ablation. I mean, I really think I was wrong about that. I still think there's a 10% chance that we maybe are adapting it too early, but I think I haven't done an RF left atrial procedure in over a year. I mean, I just can't go to do it. And so it's really been remarkable. And I would like to say that even though I'm critical of these trials, I'm not a nihilist. I mean, 2 weeks ago, I did 6 AF ablations in one day. So, I mean, you know you're not a nihilist if you do ablation of AFib. So, I mean, and it's true. And so I really appreciate the iterations and the improvements that industry has provided. But many things, whether it's our enthusiasm, marketing, so many of these new procedures bring status to doctors. Not financial status, but just status. Like they're a big person because they do a ton of these procedures, and so there's a lot of that. But there's also a lot of good things too.
Yes, and I know you're going to talk about AF ablation later today, and thank you very much for agreeing to do that. But do you find some sense of irony sometimes in the fact that your specialty is one which lacks quite a lot of evidence?
Yes. I mean, this is one of the things that made me want to write about this, because it's such an internal tension, like I'll go into the cath lab, that they're right next to each other, and we have such a great relationship with the interventional team. And they're actually it's ironic that some of the most conservative doctors in our hospital are the ones that do the procedures. The least conservative ones are the ones referring. And I'll go in there and there'll be a 90% right coronary on the screen, and I'll be looking at that, and the doc in the room will say, "John, get out of here." And I'll be like shaking my head. And I'll ask the staff, I said, "Is that a STEMI?" They're like, "Oh no, a positive stress test." And I just shake my head. But then my friend Bill, the interventional cardiologist, will come in the room, and there'll be dots everywhere on this left atrium. I mean, we've just trashed this left atrium. And he'll come in the room and he goes, "What are you doing?" He goes, and he'll look at the map. He goes, "Yeah, there's a lot of data for that too, isn't there?" So the fact that AF ablation isn't perfect, it's far from perfect, is really interesting, and I'll have a few comments about it this afternoon.
Yes, and so you have mentioned already, actually, you're married to a palliative care physician, and when I heard that a few years ago, I thought, that really makes sense, because generally speaking, as interventionists, we're so bad at end-of-life decisions and thinking, oh, this person with a Zimmer frame and who's fallen and is losing weight, what they really need to get them going is a new aortic valve. And we're very bad at that. And should being married to a palliative care physician be mandatory for interventionists?
Stacy has really helped me. I mean, she's really helped me because to any of the young people in this audience, or where I was 25 or 30 years ago, where you were at that time. I think back when we started, our challenge was having enough technology to help someone, to have a dual chamber defibrillator instead of a single chamber, to have this drug-eluting stent versus a bare metal stent, to have TAVI rather than surgical AVR. But now, I think in 2026 and beyond, I think the biggest challenge that we face in my little hospital is not whether we have something to do, but whether we should do it. It happens every day. And I don't know where these academic papers are coming from and all these people. They must see different patients than me, like the heart failure population. I mean, the vast majority of heart failure patients that we have cannot take 4 drugs. No. I mean, they can barely take 2. And so I think that's the challenge, is whether it's just making these decisions of whether we should do things.
But do you think part of that is, I mean, obviously part of it is because we like doing the thing. That's what we're trying to do. We want to do the thing to make people better. But is part of it that it's actually much harder emotionally to engage with somebody and try and explain why this is not a good idea than it is just to say, oh yeah, we'll do that for you?
It's clearly both. I think that we like doing things in cardiology. We've always been a profession that likes to fix things. I was drawn to it as a medical student when thrombolytics started for MI, because before that it was terrible. But it is much more difficult to explain to someone why they shouldn't have a defibrillator. It's really, I don't know how it works in the UK, but in my environment, we're often sent patients for a clinic visit for ICD, and they've been told they, quote, need, the verb need. Well, we need oxygen and water and food, but and so it's very difficult to walk it back, because how do you tell an older, frailer person, you're too sick to have this defibrillator? It's easier to tell them you're too good for it, but it's harder to tell them that we don't want to do this because of competing causes. Yeah,
it's definitely a tough conversation when you actually do it face to face, to look someone in the eye and try and explain that kindly.
It's very difficult. So the path of least resistance. A path of least resistance is just to do the procedure. And also in our city, and again, I don't know the UK system so well, but in our city. It's become well known who the people who will just do these things are versus the people who will put up some resistance, and referral patterns can vary depending on that.
I once heard you say, and I wonder if you still think this, because it's a slightly different topic, but along the same lines, that you said preventative medicine is there to help you, to allow you and help you to grow old. But once you've grown old, then you should kind of reconsider whether these medicines are actually offering you anything. Well, do you still have that?
I wish that we were better at education of patients and maybe the public. Is that I strongly believe that, and actually a paper from Daryl Francis's group convinced me of this, that primary prevention therapies may be most beneficial in younger, lower risk people. So we take blood pressure pills, we take cholesterol-lowering drugs in our 50s, in our 60s, so that we become 80, or 85 and 90. And I often tell patients that age 85 or 90 that they've graduated from having to take this pill. They've passed. They don't need to take it anymore. And honestly, I mean, and of course there's a biophysical, there's reasons, right? Drug clearance decreases, polypharmacy, things change. We see it with generator change referrals all the time. The patient has a defibrillator 10 years ago, and now 10 years have passed. They're older, they have competing causes, they have comorbidities, and everything's different. And it's the same with primary prevention therapies.
And so we now live in an era of information overload. You contribute to that, but you contribute well. Where should people go? Like if you're a trainee and there's so much coming at you from all sides, so many different Substack, X. I won't try and name them all because I'll just show my ignorance. But so many areas where you get information. And you even showed us this morning a couple of very well chosen papers in the New England Journal, which you can't even really trust the quality there. There are obviously vested interests somehow that get those papers in. So where should people go? How are people to glean their wisdom, if not from Eugene Grunwald?
Yeah, so I don't think there's an easy answer to that. I would offer this, that I think it's very reasonable to get the table of contents of major journals emailed to you. This is what I do. Yeah. So European Heart, New England, JAMA, I mean, those just come to me every week, and I see that. But, and I think that you keep a skeptical view, but not a cynical view, because there's a lot of good papers out there. And then I know people don't agree, but I really think X, the old Twitter platform, is very helpful. There's a lot of junk. It requires filtering. You have to like things. You have to respond to some things. The algorithm will then send you things like, I get a ton of sports cardiology. I get a ton of EP, and I think it helps. And then I think selected people's writing quite good. You know, one of the great examples, I think, is in the emergency medicine community. They were one of the early adopters of blogs, and there's very academic emergency medicine blogs about early stroke treatment. They've analyzed the trials and all different kinds of things, resuscitation science, and so I just get it from everywhere. But the social media aspect really, I think, really does help. Like at a meeting, for instance, at a big meeting like ESC or ACC or AHA, I mean, really it helps to be on Twitter to see sort of the public comments about these trials, because it's sometimes quite different than what the panel of experts say.
Now, I'm going to open this out to anybody who would like to ask John a question. So if anybody does have a question, please go to one of the microphones and ask anything you'd like. He said nothing is off limits. That's encouraging. And whilst you're thinking about that, I'm going to ask you about your colleagues. Do they get irritated with you? Because I mean, you're so well known, and we've never heard of any of them, you know. And you have to go away and do all this stuff and be famous. Does it irritate
you mean my
them?
colleagues in my hospital?
Yes.
No,
yes.
I'm not famous in my hospital at all. I've never been asked to speak at my hospital.
So they do get irritated.
They don't. No, it's really funny. My partners know. Many of my partners know, especially the interventional ones, but very few. I have no recognition at my hospital at all, and even in Louisville, not on the news, never. Which is fine. I like my role. I love my role. I ride my bike to work. I have a little locker. I come in. I have a clinic, and then I have procedures. And because I'm old and I've done all this before, I don't have any roles in administration. I don't make any hiring decisions. My partner does all the purchasing. I don't even go to very few meetings. So I just I'm done with it.
And you're a keen exerciser then, are you? You're a bicyclist.
For many years, I raced a bike.
Doesn't that give people AF?
It does. It gave me. I had AF for a year.
No.
I had AF for a year. I'll mention that. Actually, one of my examples is that my atrial fibrillation came during training for national championships, and we were doing many hours per week, and also trying night call and all of that business. But when I sort of transitioned out of bike racing is when I transitioned into riding, and so it's like that hobby has replaced that old hobby. But I still like to ride.
So is that why you say that AF is your body trying to tell you something?
What I find most interesting about this phenomenon of endurance athletics and atrial fibrillation is that when, like the Australians, and when people look into the AF structural and electrical pathophysiology, it's very similar in obese people and athletes. Left atrial dilatation, interstitial fibrosis, disorder of the electrical atrium. The same things that cardiometabolic risk factors cause happen in athletes. And I find that just a very just curious phenomenon.
Gerald, do you have a question for John?
You are a great inspiration and influence to lots of cardiologists around the world. And the question is for you, who are the people who influenced you? And in particular, who are the medical heroes you were influenced by, sporting people, people in public life? Who has influenced you in your life?
Yeah, so one of the books that influenced me greatly was Danny Kahneman's Fast and Slow Thinking. I really got a lot out of that in System 2 thinking. So that's number one. Number two, I really have to mention my friends Andrew Foy, who is one of the best thinkers in cardiology. He's just a nondescript guy from Pennsylvania. We have a project called Cardiology Trials that we're trying to chronicle every seminal trial in a 1,000-word post where people can just, we had an idea of just publishing a book where you can just look at all of the trials, ISIS, and maybe, so we're working on that. Andrew's amazing. Sanjay Kaul at Cedars-Sinai has been one of the most generous people, amazing. And so he answers my emails, he's taught me, he's given me his Bayes spreadsheet where we can do Bayes reanalysis of any trial, and now I understand how Bayes reanalysis works, mainly because of Sanjay's generosity. And so I have to say, people have been very generous to me. And it's like, it's the world now, you had mentors who were in your office next door, but now there's the world over. You can have mentors all over the place. I spent a week in Hamburg, Germany, learning to do AF ablation in 2010. I still have connections with those people, and they're still very generous with their time. And so I'm very thankful for the generosity of people.
Fantastic. Thank you very much. So, do you have a question, Nick? No, you were sitting forward. So, I think we would like to honour you from BSIS with a little award, and it's an award for having integrity in medicine. But we are mindful in making this award that you have to declare conflicts of interest if anyone gives you anything too expensive. So, so we've opted for something relatively cheap. And I have to say that, unfortunately, the bar in the UK at which that is set is currently £5. So what we decided to do was we got you a pencil. And you'll be pleased to hear that this came in comfortably under the bar at 96p. But, you see what I did there? The postage and packing actually took it perilously close to £5. So this pencil says the British Cardiovascular Intervention Society Integrity in Medicine Award, and that is awarded to the great John Mandrola. So I would like to offer this to you from BSIS. There we go, and we can have a look. There we go. Great. Thank you very much, John.
Thank you.
Absolute pleasure and privilege.
Thank you.
Come and have a seat.
Thank you.
Cheers.